I'd now like to welcome MAP Associate Professor Kypri, a fellow Novocastrian. When I moved up to Newcastle about 6 years ago now, the extent of alcohol-related violence on the streets of Newcastle, especially late at night on the weekends, was very obvious. A little bit maybe like King Street has been in Melbourne and other places in other cities. Kip is one of a number of people who has been contributed great research which has affected changes in liquor licensing, which I'm sure he'll present some data, but it is safer to walk the streets of Newcastle at night, and that's a wonderful thing. So Kip is with the University of Newcastle. He holds an NHMSC Career Development Fellowship. He has a great interest in alcohol use, and I'd like you to join with me in welcoming him this morning.
Good morning, and thank you, Adrian, for a kind introduction. I'd like to start by just complimenting APSAD on running a fantastic conference. There have been great keynotes, and I'm honoured and grateful for the opportunity to speak today. Thank you. I'm going to start by putting web-based interventions. I'm probably not going to talk about trading hours and the effects on assault rates, because the subject of my discussion is, of my presentation is web-based interventions. But I want to put that in the public health context along with those other types of intervention. And then I'm going to give an example. This is a huge area. I was given a pretty open brief to talk about web-based interventions, and it's huge and it's growing rapidly. So to circumscribe my presentation to contain it and try and keep it rigorous, I'm going to focus on web-based screening and brief intervention, and then talk about what systematic reviews show. There have been quite a number of systematic reviews of these interventions. Discuss research challenges a little bit, some of the technical problems we face in evaluating these interventions rigorously, and finish with future directions for practice, policy and research. There are quite a few areas I'm not going to discuss, and this is an important body of work developed by Australians, names you'll recognise here. This is really important work. It operates in clinical settings. I felt this was outside the scope of the brief that I'd decided on, in that it dealing with treatment seekers in clinical settings, but very, very important, often using technology, web-based technology and other technology to supplement, complement face-to-face intervention. Okay, I'm first and foremost a public health scientist. My background's in psychology and then epidemiology and public health. And for me, this work needs to fit into a framework best described by Geoffrey Rose, a famous British epidemiologist, who distinguished between population interventions, which are delivered across the whole population, and high-risk strategies, which are provided to those at high risk of a particular disorder or outcome. And in the case of alcohol or any substance where you have an agent, you've also got a supply side and a demand side. And so Adrian mentioned trading hours and Newcastle pubs. That fits in the supply side. It has no effect on demand, but limits access to the substance. In contrast, high-risk strategies such as screening and brief intervention affect demand for the substance without affecting supply. And over here on the left-hand side, we've produced some very successful demand-side interventions in Australia that have led the world in relation to random breath testing and so on. Again, these affect demand without having any impact on supply. And the table I just showed you included a number of interventions. They're conceptually included. They don't all have a good evidence base. That evidence has been reviewed several times. This is a book many of you will be familiar with, published in 2003. It's been updated in 2010, but the findings are regulating the physical availability is clearly effective, so the supply side is among the most effective strategies via taxation and restriction of hours of trade and so on, and these tend to be quite low-cost interventions relative to some of the others. In contrast, education and persuasion has been found to be ineffective in modifying drinking behaviour. And down here you've got brief intervention with at-risk drinkers shown to be reasonably effective and moderately costly. So that just puts this work in the context of the whole response. What I sometimes hear in relation to web-based programs is that they might solve the problem, or you get the impression that bureaucrats or government ministers want to discharge their responsibility to the problem by developing some high-tech solutions that are, in fact, can only ever address a small part of it. Okay, so I'm going to now talk about web-based screening and brief intervention. Most of my work in this area has been with tertiary students, and I'm going to distinguish between two settings of intervention. One is primary healthcare based or opportunistic screening and brief intervention, and population based routine screening and brief intervention. We're working with university students because on our doorstep at the University of Otago, when I started this work about 12 years ago, was a group that appeared to be drinking very heavily. There wasn't much documentation of that, but the evidence was on the street every weekend. And in fact, when we compared a random sample of 1,500 university students' audit scores with that in the general population of the same age from national survey, you see the results here. The students are presented in the dark bars. Their prevalence of hazardous drinking, scoring 8 or more in the audit, was double that of the general population the same age, and their prevalence of harmful drinking was 3 times higher. So we set about developing a brief intervention. The brief intervention literature was already quite well developed by this point, and sought to operate within the student health service, which saw more than 2/3 of the population in a given year and 42,000 consultations, plenty of opportunity to do some preventive medicine. But then we did some focus group studies, and I sat with a colleague, a clinical psychologist, and we asked students about, we ran them through scenarios in which they might come to student health, a GP or nurse might talk to them about their drinking, screen them essentially, and then offer brief intervention. And it was very clear, for a variety of reasons, different students had different negative views of different practitioners, that we had to go back to the drawing board. It was not going to be acceptable to students unless they had come in to initiate a discussion about their drinking, and that was actually an uncommon event. At around that time, there was interest developing in web programs, and we developed a web program. We borrowed these, at the time, state-of-the-art iBook computers, and set up in the corner of the student health service, which is a very busy place. The chairs are all empty here. We took these pictures during the development work in summer, but normally the place is full, and giving up this space was actually quite a big commitment on the service's part. So this program involves an assessment of drinking and related harm, criterion feedback, that's comparison of the individual's drinking against medical guidelines, normative feedback, comparison of the individual's drinking against those of relevant peer groups, ideally students of the same age and gender. Correction of norm misperceptions. One of the things we found was that students dramatically overestimated how much their peers were drinking, and their tendency to do that increased with their own level of drinking. We provide BAC feedback for a recent heavy occasion, along with physiological and behavioural sequelae of different BAC levels. Expenditure feedback, and some chronic health effects information, which we felt was an ethical requirement to include it, but in fact very few students click on that information. And the last page includes access to care and further information. So there are links to the Student Health Service, an alcohol helpline, and so on. We ran a couple of trials. This is the larger of the two, a 4-arm trial with 576 students screened in the waiting area and who sat down at the computers like I showed you. And I'm not going to go into a lot of detail here, except that to say that we were interested in an assessment effect, which is something we'd gleaned from the focus group work, concerned that simply asking the questions might make a difference. And indeed, we did find a difference between these two groups, who differed only in that one of them had assessment 4 weeks later and the other didn't. So about half of the total effect is driven by assessment in this trial. And we're also interested in whether we could enhance the intervention by providing booster feedback, and we included this D here. We didn't find a difference actually between group C and D. What I'm going to show you now is group C compared with the minimum control. So there was a 23% reduction in the volume of alcohol consumed 12 months after the intervention, 20% reduction in alcohol problems, in academic problems related to drinking, and a 2.2 point reduction in the audit score. So what's the the public health significance of these findings is fairly clear. Those are large reductions relative to other kinds of intervention. They're larger than have been found in the screening and brief intervention literature meta-analyses. The clinical significance also seems to be high. David Foxcroft had the idea of using a Bayesian, or Bayes' theorem rather, to estimate the population prevalence of alcohol use disorder from these audit scores, and we estimate that the effect of the 2.2 point reduction in audit score is equivalent to a 9% absolute reduction in alcohol use disorder prevalence. So the next question, we've made some efforts to implement that in the Student Health Service with varying success, and I won't go into detail, but I had moved to Australia by then, and had some colleagues in Western Australia who were interested in developing this at a university, at Curtin University, where only a small proportion of the students, a relatively small proportion of the students came from far away. Many of them were commuting to the university, not using the Student Health Service, using their own GPs. So this was a different kind of environment, and the question was, could we connect with a portion of students using a population-based routine screening approach, given that we had access to we could potentially access the student enrolment list. Another reason to do it this way is economies of scale. You could use a single database and web instrument for an entire country. So these are my collaborators at Curtin University. Jonathan Hallett's PhD research is included in this. And the name of the intervention, he gave it the name Thrive, Tertiary Health Research Intervention via email. I can never come up with acronyms like that. We invited 13,000 undergraduates to participate. 7,237 were screened, so that's 56% responded. A third of that population screened positive. That is a score of 8 or more on the audit, and were randomised to control and intervention. Were contacted again 1 month and then 6 months later, and you can see we had 65% follow-up, and it was not differential across the groups. And we found effects of a 9% reduction in frequency of drinking, 11% in the volume consumed per week, and 35% in the odds of exceeding the NHMRC guidelines for chronic risk. So the effects were about half the size of those I showed you for the primary care-based program. But on the upside, this program has much greater reach and costs substantially less because there's no person time cost in the healthcare setting. So I'm going to move on now to talk about systematic review evidence. So it's not all about my work. My colleague Natalie Johnson, who spoke yesterday about the Hospital Outpatients Alcohol Project, the trial of web-based screening brief intervention in the hospital outpatient setting in Newcastle. We've conducted a review of the evidence for these interventions and discovered that maybe doing another systematic review wasn't appropriate because there were already many. In fact, we sorted through upwards of 30 or 40 systematic reviews before identifying ones we were going to include. We had some review questions. Which types of ESBI are effective? For example, is normative feedback better than personalised advice? Is a single dose better than multiple dose? Or converse, the multiple dose doesn't improve on a single dose. Does the technology make a difference to the outcome? For example, web versus telephone. There are quite a few new things being tried. In which patient and population groups does ESBI work? And what settings is ESBI effective? We conducted an exhaustive search, developed these search terms using the usual procedures, and did quite a lot of manual review. We identified, with quite stringent criteria, 15 reviews. You can see the country distribution there. Australia contributed 4 of those. 10 were focused principally on e-interventions, so there were reviews in there that were examining some face-to-face or postal and telephone interventions. 5 was solely focused on college or tertiary students. 7 described themselves as systematic reviews. One thing we discovered was that there was quite a difference there's a culture, principally from psychology, that doesn't operate within the systematic review framework, but is quite keen on doing meta-analyses, and 10 of the studies included meta-analyses. These are the primary studies, so there were 70 or 80 primary studies identified through the 15 systematic reviews, and you can see the increasing interest in this over time, and the reason the numbers in 2010 and 11 are low is there's quite a long lag time before primary studies end up in a systematic review, but I'd be confident that those numbers would be at least as high as the preceding few years. And here's a summary of one of the primary outcomes, which is volume of alcohol consumed per week. Now, this column here is the effect size estimate, and a Cohen's D, a Hedges G, and a standardised mean difference are more or less equivalent measures of outcome, of effect size rather. And a value of about 0.20 is considered a small effect, a value of about 0.5 is a medium-sized effect, and a value of 1.0 is considered a large effect. So you can see that the effects are in the small range quite clearly. And just some of the key findings. Computer-delivered interventions can lead to improved outcomes at first post-intervention assessment, the implication being that the effects diminish quite rapidly over time. This study by Robert Tate and Helen Christensen, based on findings largely from tertiary students, web interventions targeting alcohol-related problems have an effect about equivalent to brief in-person interventions. And lastly, this study by Kajasari and colleagues in Britain report a mean difference of 26 grams, not the other measures of effect, which is about 2.5 standard drinks, so not a large effect. But they conclude that computerised interventions are more effective than minimally active comparator groups. But they note some quite serious analytic issues across many of the studies, which we were keen to avoid or improve on in our own HOPE trial. So which types and features of ESBI are effective? Normative feedback. No difference was found between studies providing normative feedback and those not. Personalised feedback with normative feedback versus without normative feedback, and again, no significant difference in outcome. Provision of feedback on problems, that is, so often the interventions ask about the experience of problems and provide some comment on those, and that's less effective than the other kinds of intervention, principally using normative feedback or advice. Chat was no more effective than not using chat, that is live chat within the program. And the number of sessions, 2 studies showed that multiple interventions, multiple contacts seem to improve outcome. That's in contrast to the findings of our own study, which I showed earlier. Does the technology make a difference to outcome? No real difference between web-based programs versus offline. So quite a few of the earlier studies use mailed CD-ROMs and so on. Human interaction seemed to improve the outcome. So in some cases, participants did this within a clinical setting, and there were quite large differences there. Commercially available programs were less effective, so there are a few now being marketed, particularly to universities. eChug is one of those, and they seem to be less effective than those developed by university researchers. And in which patient population groups does ESBI work? College students versus non-students, the mean difference for college, this is the effect size, is 19 grams, which is 2 standard drinks. And for others, it was much larger, 5 or 6 times that. But it's probably confounded by help-seeking status, which I'm going to explain a bit more. These are very different studies, very different types of intervention and populations. There have been no formal comparisons of help seekers, that is, people finding these interventions via the web browser, versus non-help seekers, which are the kind of studies that I've been involved with. This is people sent an email and invited to be screened. Now, I want to make a parallel with the meta-analysis, which by Moyer and colleagues in 2002, which distinguished between treatment seekers and non-treatment seekers, and finding quite different outcomes in relation to brief intervention. So brief intervention was found to be effective for non-treatment seekers, but much less so for treatment seekers in those studies. Here, the appropriate comparison is between help seekers and non-help seekers, because many of the help seekers are people who wouldn't seek treatment in the sense that we generally mean it, but are looking for something online. So in what settings is ESBI effective? Home versus research settings, help centres and workplaces, really there was no difference in effect. And home versus research settings, this is another study showing no difference. On-site versus off-site, no difference. And there are a few trials of non-help seekers outside the tertiary education setting. So there have also been some very important large RCTs that have not yet made their way into systematic reviews, or at least not the ones at the point at which we identified them. This first study by Paul Wallace, I'm going to go into some detail with all of these. I think they're important. They have implications for how we interpret what's gone before. So what Paul Wallace and colleagues in London developed a very thoughtful program called Down Your Drink over a 10-year period. This provides CBT, sort of self-help for people seeking assistance with their drinking. They screen people using the Audit C with a cutoff of 5 and randomise them to, so this is people who are registered online themselves, randomise them to the Down Your Drink website, which includes 3 phases corresponding to theoretical constructs of what's effective, decision-making, implementing change and relapse prevention exercises, or a control website which had similar graphical design and styling, and it included text-based information about the harms caused by excessive alcohol consumption. It looks more complex than it really is. They've basically done a pilot phase and then 2 phases of a larger study, and they have the outcome measured at 12 months only in the group in phase 2. But the thing to notice is the attrition. These numbers in brackets are the proportion of people still who are followed up. So at 3 months, less than half of the participants completed follow-up, and at 12 months it was down to about a third. And this highlights a real challenge. Actually, this is pretty good compared with other similar kinds of study, and it highlights a challenge of doing a trial with people you never see and you can't verify their identities or contact information. And so, and of course, it has to be delivered in this. It has to be done in this way because part of the context of seeking intervention this way is anonymity. But it's an analytical nightmare. So these are their findings at baseline. This is the baseline values. These are geometric means. So I'm not going to worry too much about the units, but just note that at 1 month and at each subsequent time point, the groups had reduced their drinking by 40%, but they both improved equally, the control and intervention groups. So this is probably regression to the mean, or at least in part. It is very likely to be regression to the mean in so much as there's natural variation in people's drinking. If you screen people in to a trial, they are probably going to improve simply because of the natural variation. You've caught them at an up point, at a high point in the cycle of their drinking. Though that's that tendency of regression to the mean increases the higher you put the threshold. In this case, the threshold wasn't very high. An Audit C score of 5 plus is appropriate, but not particularly high. You don't have to be drinking a lot to qualify for this trial. So it can only be part of the explanation. The authors themselves discussed the possibility of research participation effects. They talk about assessment effects. That is, simply being asked the Audit C might make a difference. There's evidence that the full audit, the 10 questions of the audit alone, can reduce people's drinking, measured several months later by self-report. So that's also possibly part of the explanation. And they wonder whether the text-based website that I mentioned, the control site, might have been effective in modifying behaviour. That's possible too. But still, this is a common kind of finding, a bit of a puzzle, and you can't draw an inference here about, that you'd have to conclude on the basis of this that the intervention was ineffective. Right, so the next example here is regards non-help seekers. It's a Danish study by Hansen and colleagues. They did a national survey of 54,000 people, household survey, 3,418 screened positive. This is an audit score of 8+. This is drinking above the recommended limits for chronic harm, more than 14 drinks for women, more than 21 for men. And just over a third of them consented to the trial and were randomised. So again, we see improvements in both groups and probably some small differences, about 1.4 drinks comparing personalised advice against no intervention, about 1.2 drinks. So I've gotten the wrong way around, but effects of about just over one standard drink per week. So if there are any effects, they're small. This third study involves university students. It was done in Portugal and the UK, and they found no evidence for the effectiveness of personalised normative feedback, which is a limited form of the intervention of the usual feedback intervention. But an important thing here is they didn't screen patients into the trial. They've used, it's really a sort of prevention program and it includes everybody. And lastly, we did some work in New Zealand. We continued the Thrive program by adopting it across the entire country with 7 of the 8 New Zealand universities involved. And we've run it separately for Māori and non-Māori, and I won't go into the detail about why and the context of that, but they were run in parallel, and the findings you can see here that 6,697 Māori students were invited. Just over a third of them completed the screen, and 1,789 were randomised to the control intervention group, and we've had about 80% follow-up at 5 months. These are the outcomes for Māori: an 11% reduction in the frequency of drinking, 8% in the typical occasion quantity, and 22% in the volume consumed per week. Large reductions in academic problems and in the odds of exceeding the recommended upper limits. So this work's published and accessible. We're yet to complete the analysis for the non-Māori, but I can tell you that the effects are about half the size, and one of the reasons we haven't finished is we're trying to figure out why that should be. They're about the size that they were in the Thrive trial. So, in summary, there are small effects for non-help seekers receiving personalised feedback. They're mainly tertiary student trials, and the effect sizes are between 0.1 and 0.3. It's unclear whether normative feedback's critical, but the scalability of these interventions is key. If you're getting such relatively small effects, they need to be able to be delivered to many thousands of people, and that's clearly possible. There are mixed results for help seekers. There are large effects in some studies, some of the earlier work, no effects in others. It's a very heterogeneous set of studies. The recent large, well-conducted trial by Wallace and colleagues suggests no effect. Repeat doses seem to be better than a single dose. The location of the intervention doesn't seem to matter. The evidence base is less well developed. It's a bit patchy, but the overall effect size is similar to that seen for screening and brief intervention in primary care in the meta-analysis by Kainer and colleagues. What the reviews don't tell us. Web-based interventions are widely claimed to be cheap, but are they cost-effective? We don't really have good cost estimates at this point. The limitations of self-report remain unresolved. This is the thing that bothers me the most. It's not specifically addressed in any review because no studies used objective measures to allow comparison, and the reason for that is that objective measures, so blood markers are not sensitive to the type of drinking that's being targeted here. They're even for people drinking heavily and frequently, they're no better than self-report. And they're also not practical to be collected in the context of a study in which you don't make physical contact with a user. And service utilisation measures, for example, readmission or admissions to hospital, are very difficult in this setting. They're relatively infrequent events in the scheme of things, and you'd need extremely large numbers and some capacity for data linkage to be able to do it. We've made some efforts in that direction, but haven't succeeded in being able to find a system that works. Computerised completion is better than other modalities, so you tend to get more honest reporting via computer relative to face-to-face or telephone or even pen and paper. But it remains plausible that those in the intervention group, whether they're blind or not blind to the design of the trial, are still more likely to underreport because of social desirability or other reporting biases. So research challenges. I won't say much more about anonymous participation. I've said something already. There's no clear way forward in improving follow-up rates in studies in which you have you can't get reliable information on the identities and whereabouts of participants. I'm going to talk about participation effects, sometimes known as Hawthorne effects, and then the important issue of translation into practice and policy. In any behavioural intervention trial, in the alcohol field or elsewhere, I mean, this is a standard minimal form of a behavioural intervention trial, and you can see that there's interpersonal contact at every stage. You might publish an advertisement or have a notice on a wall or contact people by email to make initial contact. You then do something to determine people's eligibility for the study. You provide them with study information. You obtain formal consent, so there's actually a contract formed. Someone's often signing something to participate. You conduct a baseline assessment, then randomisation occurs, and that's sometimes people are blind to that, sometimes they're not. And then they're told that they're in a control group or an intervention group if it's unblind, and then you do follow-up assessment. So at every stage, there's some interaction between the participant and the researcher. And there are also patient characteristics that might interact with those variables along the way to produce outcomes that, in fact, affect the effect estimates in the trial. So Jim McCambridge and I have been investigating this for a number of years now. We're looking at one of those, so just going back, we're looking at assessment here, so this step before randomisation. We've each done trials showing that answering questions, including the audit, can reduce people's drinking. And in this meta-analysis, we identified 10 studies, and the overall effect was relatively small, about 13.7 grams of alcohol, which is about 1.5 standard drinks. But that's about a third of the total effect of brief intervention, as estimated by Kainer and colleagues. So, in fact, it could be producing underestimates of the overall effect by assessing people, because there's in effect some form of contamination. That is, the control group is being treated differently than they would be outside the context of a research study. Another area of inquiry is in the effects of being randomised, or being told that you're in a randomised trial versus being in an observational study, surveys over time, a cohort study. And we've done some work recently to experimentally investigate the effects of being told you're in a randomised trial versus being in a cohort study alone. And it's early days, but we've not managed to induce the kinds of effects we're hoping to see. And I can talk about that afterwards, perhaps. So, bridging the research practice gap. One of my mentors, John Saunders, wrote that the history of medicine is littered with examples of interventions demonstrated to be beneficial, which have been poorly taken up in clinical practice. And my own impressions of, as an undergraduate psychology student, going down those long aisles of journals, was that there was a hell of a lot of material in there that had never been opened. And I think the most common number of citations of scientific articles is 0. So there's a hell of a lot of work we do that doesn't seem to even get close to influencing practice. And that's the thing that motivated me to get into this line of work. So I've been heartened by the fact that there's increasing attention. Warwick Anderson, the CEO of the NHMRC, said just a few weeks ago in Melbourne, in launching the research translation faculty that it is widely acknowledged that there's a gap between discovery and implementation of knowledge from research. Closing this gap is a daunting task exacerbated by the volume of research that's available and the need to sometimes change commonly accepted beliefs and behaviours, which I think is probably an understatement. In our own experience, translation's taken an awfully long time. This is 12 years of work, and we've got to a point now last year where the universities, in New Zealand universities, all of them, signed an MOU with ALAC, which is actually now ceased to exist, but its functions have been rolled into the Health Promotional Agency. There's an agreement for ALAC to host the web program I've talked to you about, and for universities to encourage students to access it via an email like we sent them. And this year we've seen a partial implementation, so about half the universities have done what they'd agreed to do, and I'd be hopeful that increases next year, but I'm not holding my breath right away because this takes a long time. My experience has been that to make this work you need motivated, evidence-driven, or at least evidence-sympathetic service providers and policymakers. You need committed, knowledgeable and flexible funders, and you need outcome-oriented and persistent or perhaps stubborn researchers. And I'm encouraged that we're likely to get an outcome on ESBI, but there are plenty of other areas where we've had an extraordinary difficulty in influencing outcomes. So some future directions and policy practice and research. I'm posing the question, what represents innovation in the alcohol e-interventions field? I'm not a technologist. I actually, perversely, given my area of interest by way of intervention, the technology itself doesn't excite me. Do we want more technology? I think there's some very exciting ideas out there that we need to give careful attention to because we're not doing some of the basics well. For example, utilising social media to change youth drinking norms. That's something that a few people are starting to think about or do. Alcohol screening and brief intervention via smartphone applications. I'm sure that there are many apps available right now that seek to provide self-assessment and ongoing monitoring. And we could do trials of those for sure. Or do we need to focus on the basics? For example, using widely accessible technology. The web's widely accessible now, and phone's been largely shunned as telephone's an old piece of technology, but we really haven't utilised it in the way we could. We had the experience in the HOPE trial in the outpatient setting at the hospital of discovering that a third of patients don't have regular email access at home. So we couldn't follow them up. We would have had to exclude them if not for accepting that we were going to do the follow-up by old methods using post and telephone. Non-university youth and adolescents a glaring gap in this evidence base, for example in secondary schools and vocational training institutes like TAFE. Low and middle income countries, there are big gains to be had there. Low-cost cell phones are common in some low and middle income countries, and web access tends to increase along with drinking and along with economic growth. Large, simple trials with sound design and implementation, minimising assessment, low attrition, analysis appropriate to distributions, and clear, transparent reporting. We need to rigorously investigate the validity of self-reported outcomes and do cost-effectiveness studies and high-quality systematic reviews. For example, e-screening in primary care followed by telephone brief intervention with follow-up sessions and or helpline or web support. So using the primary care setting as a catchment area, but not the place to do the intervention, and hooking up with existing sort of alcohol helplines and services. ESBI for hospital outpatients. This is an enriched population. We've found they have twice the prevalence of hazardous drinking of the general population. They're captive. They're often kept waiting for long periods. And 2/3 have web access, but many more of them are web capable. So we've had no problems in getting people to do the intervention on an iPad in the waiting area, even elderly people who've not used one before. SMS, alcohol screening and mobile phone-based motivational interviewing in India. I mean, this is a massive population with quite a lot of cell phone use and increasing alcohol problems. So I'm going to finish by by acknowledging my funding sources, in particular the NHMRC Career Development Award, which has kept me going for the last 4 years, and to thank and show you some of my co-investigators from various places. Thank you.
Great, thanks, Kip. We have a couple of minutes for questions. Would anybody like to ask a question?